Have you ever had one of those dreams, troubling dreams, where you know something bad is going to happen, but no one else seems to get it? It could be the smell of smoke in a building, or the dawning recognition that a child is missing, or a pet who can't walk right. You know something bad is going to happen because it's already begun. In the dream, you go from person to person. You say, this thing I was worried about, it's happening. We need to do something now. And everyone just looks at you. Their face is blank. They just go on about their business. I've been feeling like I'm living one of those dreams in real life. But I may not be the only one. I was recently copied on an email about opioids. Opioids are powerful pain medicines. You need a doctor's prescription for them. They can be addictive. The email came from a doctor who works in a clinic. He sent it to a medical director. It was copied to yet another medical director. I'm a physician in addiction medicine, so I got a copy. In the email, the doctor described how in the clinic they were taking patients with long-term pain off of opioids, reducing the doses or stopping them, very much as they had been instructed to do. And he was worried they were hurting their patients. His colleague's patient killed himself. His own patient tried to commit suicide and did not succeed. Both those things happened in the same week. I'm seeing the same issue. On a single day in March, I spoke by phone with 2 patients who were beginning to feel suicidal while their pain medicines were being reduced. That same day, a physician colleague approached me to talk about a relative, a veteran, whose pain medicines were reduced and who killed himself. My research collaborator and I have been receiving cases that are collected and notified on social media because we think they need to be studied. The problem is we found many dozens of these cases. But what got me about this episode wasn't just what was happening for the patients. It was also the response that came back from the healthcare leader, because it wasn't what I would expect when there is a report of a patient's safety problem in healthcare. In any hospital in America, if 3 elderly patients fall down and break their hips in a single month, leaders assemble teams to count how many such events have happened in the last 3 months. Charts are reviewed, people are interviewed, causes analyzed, resources offered. New policies are written. Those policies are sent up and down the chain of command. If someone were to say, why are you going to all this trouble? Old people fall down because they're unstable. It wouldn't be acceptable. Why not? Because in healthcare, everybody is accountable. Now, the email that came back to that frontline doctor was a little different. The medical director wrote that there is an expert in the United States who has been taking people off of opioids successfully with no suicides for many years. It gave that doctor the name of the expert and urged that the doctor contact them for advice. In effect, the message was, I'm sorry, you can't do your job very well, but there is another who can. I think it was meant to be helpful, but it struck me as passive. And it's not at all unique. The passive responses to these kind of episodes are the typical ones. I've seen this many times, speaking with health insurance executives, with healthcare bosses, with people involved in healthcare quality, with people involved in politics, with people in insurance. I tell them the story of these patients who are having terrible difficulties. The person looks genuinely concerned, and then they do nothing. The question is, why not? The simplest possible reason for leaders to not do what's normal and expected in response to a tragic loss of human life is that there's a powerful force in the opposite direction. And that really is the case here. In 2017, there were over 70,000 drug overdose deaths in this country. Over 45,000 involved opioids. Now, most opioid overdose deaths today do not involve the particular drugs that doctors typically prescribe, such as hydrocodone or whatever. They involve heroin and illicit chemicals cooked up in a lab. But I hope we all know that a big part of how we got into this mess was a 20-year run-up of prescribing opioids for pain as if they were magic fairy dust and not being particularly careful or thoughtful about it. And we are feeling the loss from that in our own communities, very often in our own families right now. And we are speaking up, as we should. And the pressure on doctors to reduce prescribing is relentless. Doctors receive letters from their bosses that say, "You have more patients on opioids than others in the group, shape up." Or, a healthcare quality agency puts out a new metric that will tell the world whether your care is good or bad, a doctor's care is good or bad, based on the number of patients who are receiving opioids higher than a particular dose mentioned in a guideline put out by the Centers for Disease Control in 2016. Or, an insurance company sends a notice that says, "We're not going to cover the cost for the opioids this patient's been on for years because the dose is higher than a particular number mentioned in a guideline from the CDC in 2016. Or, a pharmacy sends a letter to a doctor and it says, "Dear doctor, we're not going to fill any prescriptions for any of your patients, and we can't tell you why, but it has something to do with opioids." Or, the United States Department of Justice sends a letter, and the letter says, "You are one of the higher prescribers in the area." And the subtext for that letter is, "We don't know yet if you've committed a federal crime for which you will go to prison for the rest of your life, but we do want you to know we're watching." The focal point of all those letters, all those policies, all those healthcare quality metrics, all those payment decisions, and all those threats is the number of opioid prescriptions. It's two numbers, actually. The number of patients on opioids and the number receiving opioids higher than doses mentioned in that guideline from 2016. For policymakers today, those two numbers represent the difference between success and failure. In 2018, the CDC pulled together a committee of 53 national experts, people I know and respect, to answer just one question. How will we know when the prescription number is low enough? Picking a metric for success is a crucial part of doing good in the world. But you do have to pick the right one. In the United States war in Vietnam, our leaders did pick a metric for success. To pick it, they turned to a man who is known as one of the brightest business minds of his generation. Robert McNamara was a Harvard-trained Ford Motor executive who came out of industry to take over leading the United States Department of Defense. He was known as one of the whiz kids, the kind of people you would pick up out of Google or Amazon or a high-end consulting firm today. McNamara settled on a metric that was totally plausible, that was easy to count, that would keep political leaders engaged, and that could be presented to the American public every single night on television. He picked the body count. As he wrote, "We tried to use the body count as a metric to figure out what we should be doing to win the war in Vietnam. How many North Vietnamese did we take down today? How many of our people did they get?" The emphasis on the body count eventually came to be understood as a mistake. The body count created for a time the impression of success. But it turns out that you can lose a whole country while killing many of its fighters and, sadly, many of its civilians. The emphasis on the body count delayed a necessary coming to grips with what the war in Vietnam was failing to accomplish, which was to stop the spread of communism and to show that the United States was an always reliable protector. 50 years later, I am afraid that we are making the same mistake when it comes to opioids. opioid prescriptions per capita are down 35% since their peak in 2012. And yet, the total number of opioid overdose deaths is up about 250% since 2012. And I know that elevated number includes the deaths due to the heroin and the illicit fentanyl that doctors don't prescribe. But the number of deaths involving the kind of things we might prescribe, that number's hardly budged in 8 years. And all that emphasis on prescriptions has created some troubling incentives. Doctors who could see patients with pain, patients who are on opioids, of whom there are over 10 million on them chronically, they have come to see those patients as professional threats and as liabilities. And what professionals do with liabilities is predictable. They get rid of them. They refer them on, they announce a new clinic policy, anything, because they feel they have no choice. And what happens to these human liabilities after they're gotten rid of has not been closely followed. And moreover, the agencies responsible for the quality metrics and the payment decisions and the threats and the little attaboy letters and the threatening letters, they are not accountable in any way for whether the patients live or die. As a matter of fact, they don't even attempt to find out. It's not hard to check if a patient is alive or dead after you change their care, but they don't. Now let me tell you, based on what research we have, it looks like for a lot of people who have been on high-dose opioids, taking that dose down slowly, voluntarily, working with an expert, it's likely to be helpful for a good number of people. But what about mandates to do that across the board on vulnerable patients who have not consented for that, carried out by doctors who are afraid? We have no evidence that that is safe for those people or protective of them. But let me give you a thought experiment. What if someone does a database analysis and says, you know, I think retrospectively, it looks like on average, it might be protective. Put it this way. Would it be okay for a doctor to actively cause the death against their will of 1 or 2 patients in the name of possibly conferring a statistical average benefit for 8 or 9? As a matter of medical ethics, that's a hard no. We cannot tolerate interventionist policies that leave behind a trail of dead bodies in the name of possibly conferring a statistical good for some other people. Doing better for patients with long-term pain will require us to think about taking care of the people, not just their pills. That means engaging patients as partners, rather than treating them as liabilities in the way that all of these agencies have done so far. I work on a team for my hospital. We review every patient who is at high risk for overdose or suicide and who is receiving opioids. That team is led by a pharmacist. It includes physicians trained in pain and addiction. It includes a psychiatric social worker. Our goal is always that people get connected to more care, not less. And this approach requires a very different way of measuring success. We can't just count prescriptions. We have to count the number of people we are helping and take every potential harm seriously. We can change the script here in the American opioid crisis. In March, my colleagues and I sent a letter to the Centers for Disease Control and Prevention and to the Congress. That letter was signed by 3 former United States drug czars, as well as 318 healthcare professionals, over 100 medical school faculty. Over 100 pages of testimony from patients accompanied that letter. And in our letter, we said, please clarify this 2016 guideline that everybody is citing around all these policies and evaluate how it's being used because people are dying. And it's true. On all sides of the American opioid crisis, people are dying. We have to reckon with the predicament in which we find ourselves, this enormous pressure to show progress on solving a gargantuan tragedy, and worse, it's a tragedy we created ourselves. 3 weeks ago, the director for the Centers for Disease Control and Prevention wrote back. And his letter said, basically, you're right. We never intended for our guideline to be used on patients this way, and we are trying to evaluate how it is being applied in practice. Please help us get the word out. And he's right. His words need to go out to every insurance company, every healthcare quality metric agency, every regulator, every healthcare boss, people in politics, and people in law enforcement. Why do they need to hear those words? Because people are being hurt. And because picking a metric for success is a crucial part of doing good in the world. So we have to call out the deceptive logic of this prescription control. The deceptive logic of this prescription control that pays no mind to whether people live or die. It is a logic that is failing us. It is the logic of the body count. Thank you.